Okay, welcome back. Our next speaker is Abba Gumel. Abba is just moved to the University of Maryland. He is so that's nice for me because now I can just say he's a chair at the University of Maryland. Before he had sort of 5 different named chairs, which I wouldn't remember. So Abba is actually the main organizer of this conference. I think he sort of inherited that because the actual main organizer got COVID and couldn't do the end. So Abba is actually organizing this. Thank you, Abba, for inviting Abba, which we now hear.
Thank you. Yes, okay. I'd like to thank myself for inviting myself to be a speaker. No, I think the conference is
we invited Abba.
The real organizers are me and Christian. I mean, they did a fantastic job in putting it together. Anyway, thank you all for coming. My talk is on COVID modeling, focusing more on the modeling side of things and some of the lessons that we've learned we're still learning, and how we might possibly mitigate the next pandemic. Unfortunately, I have to start on this pessimistic tone that the question of pandemics of the likes of COVID is a question of when and not if. When the next one is hitting us, not if the next one is hitting us, and I'll explain why that's the case. Anyway, so the focus is basically to summarize some of the lessons that we learned, focusing mostly on some of the work that we and some others have done, some in this room, and how best we can try to mitigate the next one when it hits. Okay, and a lot of people I need to thank, and funding agencies. So MSRI funded our joint working group on COVID. We're supposed to work on malaria, but because of 2020, so we changed to COVID. And the NSF, of course, for funding our research and science foundation. I'm affiliated to the University of Pretoria, Department of Mathematics and Applied Mathematics, and we have funding from the National Research Foundation of South Africa as well. Okay, so, but at the very beginning, I always like to start these talks by mentioning the pioneers of mathematical or the history of infectious disease modeling, going back to Daniel Bernoulli's work on immunization against smallpox in the 1760s, and smallpox happens to be one of only 2 vaccine-preventable diseases that we have eradicated. The second one being rinderpest, a viral disease in cattle. So that was very influential work. I think that was probably the first mathematical model designed in and used, trying to provide insight into what's going on. And then Sarono Rose's work, first he was the first to show that Plasmodium causes malaria, and he won the Nobel Prize in 1902 for that work. But I think from the mathematical modeling community, he's more known for establishing the threshold theory of epidemics. So to control malaria, we didn't have to kill all mosquitoes. All you need to do is bring the number of mosquitoes below a certain threshold, and you have a good chance to effectively control. And that is one of his major. So I would give the credit to the whole notion of R naught going back to Sarono Rose's idea of threshold. Okay, you don't have to kill. Realistically, we cannot kill all mosquitoes.
So is that why it's called R naught?
Ross, like Ross R naught. Okay, great. I like that. That's why it's called R naught. Yeah, probably. No, that's a good point. Actually, I haven't thought of that. Maybe it's because no, he didn't call it R naught. He just said that's a threshold. So the mosquito abundance, just bring the mosquito abundance down below a certain threshold, and you have a good chance to eradicate or eliminate malaria. And then, of course, Carmack McKendrick. I'm very glad Etienne mentioned in his presentation yesterday the work of Carmack McKendrick. Mathematical theory of epidemic. It's not just SIR models. The formulated thing in general, in really excellent papers. So this cited them here. Anyway, so they laid the foundation for mathematical theory. And notice none of them really is a mathematician. None of the findings are, except maybe we count Bernoulli as a mathematician. But the others are not, and they laid the foundation. They're medical people. They're biochemists and epidemiologists and so on. So, but that's the fundamental work done at the early stages of the mathematical modeling of infectious diseases. Okay, so it's a collaboration between mathematicians and public health people. And when I say public health people, talking about epidemiologists, ecologists, clinicians, all sort of people that are involved in, from the biological point of view of control of diseases. So it's a collaboration between mathematical scientists, and mathematical scientists to me means mathematicians, statisticians, computer scientists, and so on, that use mathematical approaches to understand the spread of diseases and how best to control them. So public health people have their own wish list during early stages or during outbreaks of diseases. So early estimation of epidemiological thresholds, for example, like R naught. So R naught meaning Ross's naught. So I like that new definition now. So early estimation of basic reproduction number or herd immunity threshold, which I'll talk about a little later, or disease burden, was expected number of people that will be infected, or that will be hospitalized, or that will unfortunately die of the disease. That kind of, so maybe yesterday we had talks discussing final size of the epidemic, right? So I talked about that yesterday. So determining qualitative nature of the spread of the disease and so on. And assessment of control studies, we had a very good talk this morning about testing and then contact tracing yesterday as well. All of these things, they cost effective in minimizing the burden of the epidemic, especially when you have limited resources, limited allocation of those resources. Okay, so that's the public health wish. But then we have mathematicians or mathematical scientists, so we have our own wish list. And so what we do is we, in interaction with the public health people, design mathematical models that provide some insight into what's going on, but we also have our interest in trying to determine the qualitative properties of this model. So it's typically existence and acidotic stability of the solutions of the model. Maybe do some bifurcation analysis. And that's the reason we do the bifurcation analysis, because it tells us in parameter space, under what conditions do we reach persistence or elimination of the disease or effective control of the disease. So they are important. There's also statistical components. So we collect data, we fit the data models to the data, and then use that to estimate unknown parameters, and then make predictions afterward. And maybe study also the impact of uncertainty in the estimates of the parameters on the outcome of the simulations that we have. So all sort of interest from the mathematical, statistical, and even computational point of view. I mean, some people use computational intensive large-scale models like agent-based models, for example, and network models that require high computational power and so on. Okay, so there are different types of models. Focus mostly on compartmental modeling. But others, I think yesterday we talked about meta-population models, spatial models, agent-based. Depending on the type of model you choose to use in times of epidemics, depends on the kind of question you want to address, and also the type of data that you have available, I think. So if, for example, the question is to determine who infected whom, then it makes a lot of sense to use agent-based modeling, right? It tells you use, but for most of my purposes, I think compartmental modeling seems to be adequate. So typically we split the total population into mutually exclusive compartments based on disease status. And could be deterministic, could be stochastic, discrete time, or delay differential equation type stuff. But anyway, the type of model you choose really depends on the kind of questions you want to address and the level of data. If you have really detailed data, then agent-based model may be appropriate. But I still question whether you can have the level of data needed to really come up with good agent-based models. But this is something we can debate later. Okay, so a simple SIR Carmack-McKendrick spatial kit, or this Carmack-McKendrick formulation is given by this. So S is susceptible, I is infected, R is recovered or removed. And this is for an epidemic, which means a disease that we have not seen before. No one has prior immunity. So the only thing that can happen to a susceptible person after interaction with someone in I class is potential for infection. If that happens at rate beta, then the susceptible moves to the I class. And the only thing that can happen in the I class is the infected person can recover at rate gamma and move to the R class. And these are the solution curves clearly. So susceptible depleted a little bit, but not all susceptible people get infected. So infection reaches a peak and comes down, dies down to zero, and then most of the all the infected people recover eventually. And that's basically it. So this model has just one equilibrium or line of equilibria actually given by this, and there's no bifurcation here. Regardless of what R naught is, the disease dies out according to this formulation, right? That's the underlying assumption. Diseases come and go without affecting every member of the community. That's one of the main conclusion from the Kamek-McKendrick formulation. And yeah, and that's no bifurcation. So even if R0 is greater than 1, the disease dies out eventually. And this was widely used to model the plague and cholera in different settings. The key assumptions, okay, this homogeneous mixing, we talked about that yesterday a lot. Exponentially distributed waiting times in all epidemiological compartments. Large populations, therefore it can be deterministic, it doesn't have to be stochastic. If it's a small population, then stochasticity is important. Permanent natural immunity, once you recover, you never get it again. So it's like shingles or chicken pox, for example. You get it, you don't get it again until later on you have shingles. The time scale of the disease is assumed to be much, much smaller than the demographic time scale, so that you do not have to include birth and death processes here. So that's another, so there's so many assumptions. So the reason I'm spending time on this is, I mean, models are basically, the output of models depends on what you import, I mean, what you put in. So what you put in are initial data, but also the assumptions in the design of the model. So the assumptions, you make a lot, and homogeneously mix. I mean, everybody is equally likely to mix with everybody else in the community and acquire infection from that person. So based on this assumption, we can make predictions. But anyway, the point is that, there are models and there are also models. So it depends on the assumptions you make in the formulation of the model. So for any questions at this stage? No, okay. All right. Of course, this is a simplistic possible model maybe one can use. And in fact, this, you can show that this reduces actually a simple logistic equation. So dx dt equals alpha x plus 1 minus x. And that's why at the early stages of an epidemic, simple equations like logistic equations can fit the data quite well. This one is essentially a logistic equation. Okay, so, but this, of course, you can extend to add all sorts of heterogeneities, like age structure, like risk structure, spatial structure, mixing structure, various interventions, multiple variants, evolutionary aspect, climate change, zoonosis, and all sorts of things I can incorporate. The more heterogeneity you add to the model, of course, the more complex it becomes, and in some cases, it becomes less mathematically tractable if you do that. That's always a trade-off, right? You're adding heterogeneity, you're making models more realistic, biologically, epidemiologically, but mathematically, not much probably can be done in terms of analysis. But again, it depends on the questions you want to address. Okay, so now I want to talk about R0. This is really important. We talked yesterday. I understand there was a discussion, I don't know, a few weeks ago maybe, on what is the real definition of R0. So the classical definition is that's an index case here, and so black people who are not infected yet they're susceptible. I read someone infected, so the index case is the very first case. So in this case, R0 is 2. So the naught in R0 means completely susceptible population, meaning no one in the population has prior immunity, no vaccination, no quarantine, no intervention whatsoever. So that's the naught. 0 here means that. So this is a completely susceptible population. You introduce a single case. If R0 is 2, then this person transmitted 2 others, and this guy transmitted 2 others, and so on. Before you know it, all black will become red. This is a completely vulnerable population. The disease is spreading, and there's no public health intervention, and no one has prior immunity. And the second case is if you have control. So there's RC, control reproduction number, where there are some people in blue. So those are people that have prior immunity. Either they've been vaccinated or they have seen the disease before and recovered from it, so they have some protection. They're not completely as susceptible as those in black, and that's the control reproduction number. And R0, mathematically speaking, is a spectral radius of some matrix. So let me quickly show what that means. So for example, if we have a simple model, S dot equals pi minus beta Si over n minus mu s, this natural death rate is for an epidemic, and there's E class, which is the exposed class, basically people who just got infected, but they're not yet infectious. And mu is natural death rate. Sigma is 1 over sigma is essentially the incubation period. So let's say gamma is the recovery rate, mu is natural death rate, and delta is disease death rate. Gamma I minus, let's say mu R. And suppose for this setting, the SEIR model, for this basic SER model, if you recover, you do not become susceptible again. So here R0 classically is always infection rate near the disease-free equilibrium, okay, near DFE, times average duration of infectiousness, times how long you are able to infect people, average duration of infectiousness. Okay, so what does that mean? So if I'm infectious, okay, what's my rate of infecting susceptible people? So it's this guy here, this coefficient, but near the disease-free equilibrium. Again, because this person is introduced at a population that is basically at disease-free equilibrium, except for that person. So that's why when you compute R0, it's near the disease-free equilibrium. So it's beta S star divided by N star. And okay, and the disease-free equilibrium here, the equilibrium is when you set the right-hand side to 0. So the disease-free equilibrium has, is given by this a star just to indicate. So this will be, in the absence of disease, this guy is 0. At equilibrium, that's 0. So pi minus bs is 0. So this is that. So at the disease-free equilibrium, we're at the carrying capacity pi by mu. So the infection rate is my ability to infect, if I'm in I, is given by beta, but I'm infecting only the proportion of the population that are currently susceptible, which is S of t divided by N of t. But at the disease-free equilibrium, so beta S star by N star. In this case, S star and N star equals 1, right? Because N star is S star plus E star plus I star. So N is the total population, is S plus E plus I plus R. So that's infection rate near the disease-free equilibrium, times the average duration of infectiousness. Okay, so my duration of infectiousness is here, is 1 divided, how long I stay in the I class because of the exponentially distributed waiting time is 1 over gamma plus B plus delta. You can see if you solve this I dot minus this term, if it equals, if you only consider this, you see this is an exponential distribution which mean 1 over gamma plus B plus delta. But in order for me to go to the I class, I have to survive the E class. So what's the probability? The probability of surviving the E class is sigma divided by sigma plus mu. So I've survived the E. If I've transmitted the disease to someone in S, this someone in S is now in E, and they have to survive the E class to go to I with this probability. And once they're in I, how long can they transmit infection is 1 over gamma plus. What do you mean by surviving the E? Yeah, meaning they didn't die while in E, or they didn't leave while in E. So so they survived the incubation period. So you got infected today, there's a time lag before you can start transmitting. So it's about, for COVID, initially it was like 12 days, then later it was changed to 5.1 days. So you survived that period, but you didn't die, okay? So you're still infected, you didn't die, you didn't recover, so you go to the I class after that. Very good. So that's the R0. So S and I, N will cancel out, that's R0. But it also can be obtained using the next generation operator method. So what we need to do is just find two matrices. So you see, this infection rate near disease-free equilibrium is the matrix F. And this average duration of infectiousness is actually the inverse, because it's how long you stay in a compartment is 1 divided by the sum of the linear rates leaving that compartment. So it's essentially the inverse of some matrix. So F is the matrix of new infection terms. So basically, and we only care about the E and I. So what's that? Okay, so look at so if this is E, this is I here. So the new infections in the E class is basically beta S star, which is coefficient of I. So it's this 0 here, there's no individuals in E class do not transmit infections. So this is, but those in the I class do at this rate near DFE beta S star over N. And in the I class, there are no new infections, nothing in beta, so everything is 0 here. So you have this 2 by 2. And then the inverse, the V matrix, is the matrix of the linear transition terms leaving the infected compartments or coming into the infect. So this one is, so here we change the sign, so it's sigma plus mu. This is again E and I for E, and there's nothing in I that's linear. In the first equation, the second equation, this is sigma for E, but we change the sign. There's a North American notation and the European notation, so I'm sticking with the European notation, the North American notation, and then this is gamma plus mu. You just change the sign. And R0, this expression we got will be equivalent to this. The spectral radius of this matrix. There'll be so you find the eigenvalues of FV inverse. There will be 2 of them. One is 0, the other one is non-zero, which will be exactly that. So that's the sorry. Yeah, so a row of FP immerse is, maybe I put the computer. Yeah, so this is it. This is it. Is it the dominant eigenvalue? I think was discussed. Yeah, Jason.
Yeah, quick question. So this. Oh, sorry, Christian. So this is really great. So the way I usually think about the way you've written down the equations for SEIR is like a deterministic system.
Yeah.
And then the latter way you found the basic reproduction number is based on this Diekman method. And
Yeah,
that works always for the deterministic system when you can work it out. But the first way you derived it, you're all of a sudden interpreting that as if it were the stochastic case and doing it all in terms of expectations, right? So
essentially, yeah. The first part, the first way I did it was by inspection. Not by inspection. It's not by using linear algebra, just following the infection. So if I'm here, how many new cases am I going to generate during my lifetime of infectiousness?
yes, so the first one, right? It seemed a little heuristic, but I mean, it could be made formal if everything is the expected values under the stochastic interpretation.
I like that. Yeah.
Yeah. But so when do you know when they actually agree? They agree here, right?
I didn't check that, but I would. Yeah, I think for me, this is classical. This is a classical definition of R naught. R naught is my ability to transmit the infection to someone, and how long I'm able to do it. The product of the two, that's R naught always. My contagion capacity, my capacity to transmit the infection times how long I'm able to do it. Yeah, that's basically it. So if this agrees with the stochastic formulation, that would be fantastic. Yeah, but I didn't check that, but that's a very good point. Yeah. Yes, Greg.
Were you at the discussion Monday a week ago?
But R naught?
No, I see. So this is exactly the discussion we discussed for 90 minutes, and we decided you could discuss for another week. So the answer is it's actually very non-obvious in the general's case how to even define it correctly.
Yeah, we should have that discussion again, please. Greg, yeah.
I just have a comment. So one way in which you can think about it is the sort of classical deterministic SIR equation. You can think about it as a master equation for a certain stochastic process. And if you do that, this actually turns out that those two are equivalent definition.
Yeah, very nice. But there's also the notion of target and type reproduction number. So these matrices, I mean, you can, the way you generate them could be different depending on what you enter into F and what you enter into B sometimes. Like, so we had a paper on cholera. So we had like 4 or 5 different reproduction numbers, and depending on what this is an M matrix, right? So it has this, the diagonal elements are always non-negative. So they're always positive, and the up diagonal are non-positive. So that's an M matrix. So you can take into, you can use some of the theories of Perron-Perrin theorem, like of positive matrices based on the structure of this matrix. And this is a strictly positive matrix. No, it's a non-negative matrix, the F of new infection. It's a non-negative matrix of new infection terms. And this is the M matrix of linear transition terms. So it's just like follow the money. Here we follow the infection. When you do the next generation operator method, this is the method by Otto Diekman and Hestebeek and Meth in the early 90s. Yeah. And they presented in a simplified version. I think this is a very theoretical paper, fantastic paper, but presented in a simpler way.
So already if you have, let's say, 2 types, males and females, and different sort of, let's say you have AIDS and males and females and homosexuals and non-homosexuals, and you have sort of types, this is still the correct definition, but it's very hard to give already then it's not, you can't just choose a random member of the population initial case that will give you a different number, and it's a wrong number. And this leading eigenvalue is the correct number. And there's some way to make it the same, but you already have to think a little. And the more complicated the model is, the more you have to think to get a reasonable or not.
Yeah, so it says the average number of new cases, the definition is average number of new cases generated by a typical infected individual introduced in a completely susceptible, a typical, not ever infected. Because if I'm super spreader, I may infect 100, but Amin may infect 2, Christian may infect 1, you know, so Jason may infect 1 million, for example. I like Jason. So that is so that's why we take the average, a typical, you know, so in the definition, we're very careful to say it's a typical, not every infected individual. But then you take for the average, the average number of new cases generated by a typical infectious individual introduced in a completely susceptible population. Yeah. Anyway, sorry.
Really important that typical infectious individual, a typical individual who is infected is not a typical infectious individual.
Absolutely.
It's
Right.
people are more susceptible.
And we had a long discussion whether a typical infectious individual is after one step of the infection or after 100 or
However
and-
long it takes to stabilize an
Well,
infinite sized population.
and if you don't have exponential times, it's actually very unclear what typical means.
Well, there's a nice piece of work done actually by Zilan Fang at Purdue on using gamma distributor waiting times instead of exponential distributor waiting times. And the expression for R0 seems to be somewhat similar, more complicated, but similar, I think. But anyway, we can discuss, but I think we're due for another discussion about R0.
Yes, maybe next Monday.
Okay, yes, that should be great. Okay, so let's talk about COVID now. I know we talked a lot. This is the story, so I'm not going to say too much the details, but December 31st, that's when officially we were told of this strange pneumonia-like illness that was spreading in Wuhan. And then they did the sequencing and they found that it was actually caused by coronavirus, and it was spread rapidly within China initially, and then neighboring countries, and within a few weeks, basically to all parts of the world. And the WHO had to declare it a global pandemic March 11th. So this is an important date. I'm coming back to it later, March 11th. And we so far have lost about 6.6 million people. It represents the greatest public health challenge since the 1918-1919 pandemic, the H1N1 pandemic that hit particularly Europe really badly. Anyway, so yeah, and so there are a group of RNA viruses that been causing diseases in birds and mammals, you know, and the transmission modes we talked about, all sort of. But I want to highlight this: the chronology. Cannot pronounce my own word. Chronology of control measures. So the spring of 2020. So the index case in the U.S. was brought in, I think, January 20th of 2020 here in the Bay Area. I don't know which particular location. Anyway, so basically what was implemented at the time essentially was community lockdown followed by, oh, no, where is Hamza? It's called conservative, what's the word? It's taken by, oh, okay, conservative community lockdown. Okay, that's what happens throughout most places. Yeah, I like that, conservative community lockdown. Social distancing and masking, that's the spring, mostly that was what was implemented. And in the summer, and masking and some social distancing. And then we got the vaccines, the two mRNA vaccines, Pfizer and Moderna, approved for use, given the emergency use authorization by FDA in December of 2020. But by the time they're deployed on large scale was sometime in the spring of 2021, around March, I think. Anyway, so vaccination and some non-pharmaceutical interventions. Right? So that's really the main history. So the question I wanted to address is, okay, could we have altered the trajectory of the pandemic if we had done certain things differently? What did we learn from the pandemic? Causing 623 million cases, confirmed cases globally. And this is hugely underestimated, by the way. Even the CDC acknowledged that because of the problem of asymptomatic, pre-symptomatic cases, transmission, the number of cases we have, reported cases, is a gross underestimation of the actual cases. So, and that's why at the beginning, I think it makes a lot of sense to only use mortality data to fit models for COVID rather than case data, because case data clearly, I think the estimate by the CDC is like 10-fold lower than the actual. This is what the CDC director, the previous one, said.
Are the deaths, do we believe they are correct, or is that by 10% off, by 50, by factor 2?
The death, I think the death at the beginning was not great. Also, but I think later on, the mortality data was very reliable. At the beginning, yes, they're not counting those who died in residential care facilities and those who died at home. But later on, I think a few months later, we got better at that. But the case data up till today, definitely no. I mean, we cannot detect, unless we do large scale random testing, there's no way we can detect someone who's asymptomatic and pre-symptomatic. I mean, therefore, the case data by definition is just not reliable. Yeah, okay. at least for COVID. I mean, for other, like the SARS, the first one, yes, case data was very good because the people doing the transmission are the symptomatic people. So the case data was very reliable, 2002, but not this one. Anyway, so this is zoonotic, and this is one of the main things that I'll highlight through in this talk. COVID-19 emerged out of birds and pangolins, maybe some intermediate hosts, but starting from bats all the way to, and bats are the usual suspects for most of deadly diseases, largely because their immune system is designed in such a way that they are good reservoirs for many terrible diseases, but the diseases don't kill them. But then bats, I was given a lecture, this was at Nimbus a while back, and I say, well, why not just find a way to get rid of all bats? But then I was told that bats are very useful to the agricultural economy, like in Texas alone, like $1 billion worth of their droppings are very useful in. So anyway.
Not to mention the Batman movies, you know.
Oh, yeah, that too. Yeah, the movies also. Hollywood loves bats. Yeah, okay. Yeah. So anyway, this is so this is MERS, the one Middle East respiratory syndrome, which emerged out of Jordan and Saudi Arabia in 2012. It's still spreading through camel to humans. And this one, the swine flu, remember the 2009 H1N1 started out of Mexico and the United States, right here through the swine. Jorge is here, he can say some more on this. And yeah, so all of this, this diseases, this terrible pandemics essentially are emanating from animal population. Malaria, we didn't have malaria until about 12,000 years ago. There's malaria, the Plasmodium has always been around for millions of years, but spreading only in lizards and other non-human primates. It's only 12,000 years ago that Plasmodium jumped into the human form of malaria. And the reason is obvious because this is the beginning of the last ice age. The world was getting warmer and warmer. Agricultural civilization, opening up breeding habitats for all sorts of diseases, including malaria. And that's, so the point of this slide is to say that if we're leaving them alone, if we're not encroaching their natural habitat and destroying their natural habitat and pushing them away, many of these diseases that we've been dealing with or have been dealing with for decades will not have happened. They will have been just restricted to just zoonotic diseases, not human. So it's anthropogenic. It's things we as humans do to the natural environment, to the ecosystem that makes us vulnerable to all sorts of diseases. Yeah, so it's a recombination of bats and pangolin strains, the transmission through the wet market. So again, tourism was mentioned yesterday and today as well. And it's possible also it started by accidental leak from some lab. We do not know for sure, but bats are implicated for this. What else? Okay, so we've seen, this is not the first time we've seen coronavirus. I've mentioned before, at least two others before COVID-19. So this one, the first one, started out of Guangdong province in China, 2002, 2003, spread to 29 countries, caused about 744 deaths globally. MERS started out of Saudi Arabia, 27 countries, but case fatality ratio about 34%. The good news about the two is that their R naught was lower, even though they have a huge, imagine if COVID has case fatality ratio of 34%. My goodness, 34%. So 34% of people with symptoms will die. I mean, that would have been, wow. It would have been more than the H1N1 pandemic of 1918. But luckily, the case fatality was initially about 2.5, then it decreased to 2, and now down to 1.1. We're getting better and better, and vaccination played a major role in this as well. Okay. All right, so I will describe some models that we...
Wait, you sort of teased and said, what could we have done better? Will you tell us that?
Absolutely, yeah. That's the whole point. I'm just starting the presentation now. Yeah, I'll say that, yeah.
So,
yeah.
Can you go back one slide?
Sure.
So this
case fatality ratio, I mean, people mix that up with the infection fatality ratio. So the case fatality ratio depends on also how many people that had a disease that are tested positive. So the risk of dying is probably somewhat or fair amount smaller than that.
So here, how I calculated this is the number that died. Let's say the 627 million are the total confirmed cases globally.
But you said it's probably factor 10 larger. So actually it's only 0.1%.
That too, yeah. I should have done that,
That's what he's saying.
Yeah, this number is definitely lower than the actual, yes.
Do you have a comparison between the R0s for the 3?
Yeah. I have comparison between the R0 for the 3, yes. So I think for SARS at the beginning, So I studied SARS a lot, actually. This at the beginning was like 1.2, 1.3, less than 2, definitely. And then when we start, and this was controllable using basic measures. Almost all the modeling groups predicted exactly the same thing. Neil Ferguson's group, Mark Lucid's group at Harvard, our group, I was in Canada at the time, so we wrote a Royal Society paper. Everybody was saying SARS was a disease that was controllable using basic public health measures, just quarantine, isolation, hand washing. You didn't need any pharmaceutical intervention. The reason was because R0 was low, and also the main drivers were symptomatic people with symptoms. And they are mostly younger people, because older people had prior immunity. So we quarantined in Canada at the time over 4 million people. We're talking this morning, 4 million people were quarantined in the whole country. And I think it was mostly a big problem within the Greater Toronto area. But the R0 for SARS anyway was 1.5 at the beginning, 1.2, and then it quickly went down to 0, below 1, and it died out within 6 months, 9 months. That was it. The disease was gone. For MERS, is still, I have a student working on it. It was also very low, nowhere near 2, so slightly above 1, and it came down as well. Yeah. And it's only spread right now in 2 countries, in Jordan and Saudi Arabia, and it's largely to do with the camel riding, the horse, the camel exercise they have, the sports or something like that. So there's the disease is spreading in camel, but then because of proximity of humans and camels, they're having cases. So but only, as far as I know, only in those 2 countries. But they are not, yes, COVID, when it came, they are not initially, Neil Ferguson group estimated it to be 3 to 5, and that's at the beginning. So it's much higher. Even now with Omicron, of course, it's much higher or not. So it's Omicron, but it's not as fatal. So yeah, it depends on so this is more contagious. And that's why the main differences between COVID-19 and the other 2 is, first of all, the role of asymptomatic transmission and pre-symptomatic transmission, which was not the case for the other 2. People who are asymptomatically infectious and pre-symptomatic were not the main drivers of the epidemic for the other 2, but this one, they are the main. I'll show you some data that shows they are the main drivers. And it's more transmissible. It has higher R0, essentially, yeah.
You mentioned that for the original SARS, older people already had prior immunity?
I think so, yeah.
So wait,
there was some sort of,
question, please.
Oh yeah, so I said the original SARS, the older people have prior immunity. Yes, I think that's what's.
There was some kind of coronavirus like it going on around China before.
In the past, yeah, probably. I'm not sure, but I know people have said that. Yeah, because most of the cases, at least we know in Canada, was mostly younger people. Yeah.
Sorry, I probably missed this, but like,
Too many questions.
I'm sorry.
Oh no, it's okay.
Not a very good question, but
No.
so Poland did like a bunch of random testing, right? Like a national scale.
Yeah.
Random, like, is that what people use to estimate like the like that you're 10x below or anything like that, like in terms of the number of cases or deaths? And is that consistent across? I guess I don't know if previous epidemics had like such a large scale testing regimen. Like, is that consistent, the underestimated ratio or whatever?
I think it's possibly that, but I know at least I know what we did. What some other groups have done is just to fit the data, the model was data, and then use that to say, okay, what of all those new cases, which ones are attributed by fitting the transmission rate for asymptomatic and pre-symptomatic, and see what's the proportion
on Poland data.
Yeah.
Got it.
Yeah, exactly. So,
great. Okay.
Yeah.
Okay. I see. So you said not quite as fancy, but you trained a model on Poland data and then fitted the world. Is that what
sorry,
you
no,
said?
I didn't mean Poland. We use US data. Sorry, we didn't use Poland.
Poland is the one that did the large scale testing. I thought that's what you mentioned.
No. So the US CDC are the ones who said actually the case data for the US was grossly underestimated. The actual data, the CDC. I didn't use the Poland data. Sorry. Yeah. No worries. Okay. All right, so this is a simple model we can use for COVID, but so susceptible, exposed, and then you become a pre-symptomatic IP, and then at the end of the pre-symptomatic period, a proportion R will show symptoms, go to IS, and the remaining proportion will not show symptoms and become asymptomatically infectious at the rate sigma P in this case. And then after that, they recover at rate gamma A. These ones will recover at rate gamma S, and this one will be hospitalized at rate PS and recover and so on. So it's a simple model, and this transmission rate. So I just highlight there are 4 sources of infection. I mean, so someone in the pre-symptomatic stage can transmit someone in the asymptomatically infectious stage. And the other one is hospitalized. At the beginning, hospitalized people were transmitting, but later on, of course, they were not. So, and symptomatic people were also transmitted. So 4 main routes of infection. If you are susceptible, coming within 6 feet of someone in the IP class, IA class, IS class, and IH class can result in infection. And the deltas are the disease-induced mortality in the S class and the hospitalized class. So people do not die in the pre-symptomatic and asymptomatic classes. So again, this is an epidemic model. So the way we formulated it, there's no demographic. So again, the time scale of the disease is assumed to be much, much shorter than the demographic time scale. So in the US, for example, people live on average to be 79 years. But for new diseases, we assume that it's going to disappear within like maybe 2 years, something like that. So 3 compared to 79 is small. So that's why we do not include demographic at the beginning. But later on, when we started vaccinating kids and so on, and the disease has been around for like two years already, 2.5 years, then it makes a lot of sense to include demographics, particularly because we're vaccinating younger people. So anyway, so lambda is the infection rate, and then you get infected, so you move. So this is basically the equation based on the flow diagram. Okay, so we fitted this model. Oh, yeah, before that, okay, so this is the pre-lockdown and lockdown period, and I'm looking at 3 states on the entire US. Arizona state, the state of Arizona, I was there at the time. So we want a lockdown during March, on March 31st. So, and the first case was reported March 6th for the state. So between March 6th and 31st, we're not in lockdown. That's called pre-lockdown period. And the lockdown period is that, and we reopened the economy May 15th. So then we became less conservative lockdown. So we are conservative lockdown during that, and then May 15th we declared. Anyway, yeah, exactly. So anyway, this is Florida. It's the same thing, and New York. So notice New York was the first to go on lockdown, March 22nd, and they stayed longer than everybody else until May 28th. Okay, and then we estimated, okay, the entire country, okay, maybe by April 7th, pretty much the whole country was in lockdown, and we stayed on lockdown until New York decided to. Yeah, I mean, that's our, anyway, in this paper, that's what we did. So we fitted the model using data available at the time, pre-lockdown and lockdown period. Okay, just simple least square regression basically to fit the model. Okay, and the top ones are the lockdown, no pre-lockdown period, the cumulative death. Again, during the early stages, I was only using mortality data because I thought it was more realistic. And this is the cumulative death for the 4 locations or jurisdictions, but during the lockdown period. So in either case, the fitting seems reasonable. And we use, so in this model, the only parameters really we do not know for sure the betas, those 4 betas, I think, and possibly maybe the deltas, the disease-induced mortality rate. So we could fit the model with the data to estimate, find the best values of these parameters that we do not know. That's the whole point of fitting the model with data, right? To estimate unknown parameters. So we did that, and now we can make predictions to having obtained the best values of those unknown parameters. And what we did was, okay, to say, well, if we have fitted the model to obtain those 4 parameters that we do not know for sure, can we then go back to the model with these fitted values and then run the simulations of the daily cases and compare with the observed daily cases to see whether we do well? It's a way of validating our model. And this is what we got here. This is for Arizona, this is for Florida, this is New York, the entire US before lockdown and during lockdown. And the dots, red dots are the data points. And this is for the daily cases. So you see all the, it seems reasonable. Of course, it's not a perfect fit, but it's reasonable. We did better actually in New York compared to other 3 jurisdictions. But anyway, it seems reasonable. So we are satisfied with our answer. So having fitted those parameters, now we can generate, okay, who are the main drivers of the epidemic among the 4 routes? The pre-symptomatic, asymptomatic, symptomatic, and the hospitalized people. So based on the fitting, we just calculated the proportions. So beta P divided by the sum of all the betas, essentially. So during the pre-lockdown period, in Arizona, for example, the pre-symptomatic people accounted for about 47% of the new cases based on parameterization, and asymptomatic was 19%. So in the whole Florida, New York, the entire US, the same. So the conclusion is they account for at least 70% of all new cases, those pre-symptomatic, asymptomatic people, based on our data. So they are the main drivers of the epidemic. And what does this tell me? Okay, well, it tells us straight away, right from day one, perhaps the most effective strategy to use would be one that targets detection of these pre-symptomatic and asymptomatic people. And what will be that strategy? That strategy has to be testing. It's clear, but it has to be large-scale testing, not just testing people with symptoms. They are not the main drivers of the epidemic. The main drivers are, and I think it's still the same, the main drivers of the epidemic, maybe not the same percentages, but it's still pre-symptomatic, asymptomatic people. And the only way to know that, because they don't even know they are sick themselves. They don't even know they're infected. And they're mostly younger people. So the only way to detect them is through large-scale testing and random testing, large-scale random testing. Anyway, so that's the first conclusion. Okay, and the second one is, okay, what's the impact of early lifting of lockdown measures?
Excuse me, Abba, I think that there is a question.
Oh, that's a question, sorry.
Can you show the previous slide, please?
Yeah, of course. Let's go back.
Why is it that the column US give very different figures from the 3 first columns?
Yeah, so we fitted the entire US data. So we fitted the data for the state of Arizona, only Florida, New York, this is the whole US. So some places didn't have a lot of COVID cases in the US. Some states basically did really well. Others didn't. So on average, we get in these numbers, yeah.
It's strange because it's very different.
Yeah, very different from, well, New York was hit the hardest than any other state of the US.
No, but what he seems to be saying is your US, if you add pre-log and pre-symptomatic and asymptomatic, or this is sort of around 60%, and all others are much larger. So is that we Californians made up for it and we have much less?
Possibly. I mean, yeah, but still the same. I mean, it's accounting for at least 50% of all new cases. I mean, even if that's huge, even if we say just 50% of all new cases are generated by people who have no idea they have the disease.
And how did you estimate those proportions?
So using the data. So we fit the model with the data for each state. So the betas are the parameters we do not know. So we estimated them by minimizing the sum of squares, of basically least squares and any other.
So I have a question on your estimates. Your models, so you're using the sort of very simple McCormick equation, which is differential. And we sort of learned yesterday, and some of us learned maybe a week before, that there is sort of the integral equations. And to assume that COVID has a time which looks like that decays exponential rather than a peak and which dies down after. So how sensitive is this actually to having an exponential distributed infection time? Because that is super unrealistic. That's probably the most probabilistic assumption in your model.
Well, yeah, it's a simplifying assumption to say the washing time in each compartment is exponentially distributed. But what I was arguing, the work I've seen in the past was gamma distribution and some other distribution. At least the expression for R naught tend to be, and the fitting is much better actually if you do gamma distribution.
Right. So but could you have done this with gamma?
Oh, sure. In fact, some of the later works that this was done like 2020, this during the lockdown period. This was like June of 2020. So yeah, later on we use gamma distributed waiting times. So yeah.
Do you have an idea about the precision of your estimates? I mean,
95% confidence interval. Yeah, we calculated those. Yes, and you can also compare.
So how large are those confidence intervals?
How large? Sorry, say it again.
I mean, you give data, you don't give us the confidence interval.
No, I didn't. Yeah.
It's plus or minus what, 2, 1, 5, 10?
No, I can't remember that. Okay. Yeah, it was a long time ago. I was just, for me, when I saw this number, I was scared at the beginning. My goodness, is that really what's going on? Then I saw other groups as well. I think Alison Galvani's group at Yale also came up with similar numbers. That really surprised me. But anyway, yeah.
Question?
Yes, sorry, yeah.
You can repeat my question?
I will repeat your question, yes.
How do you estimate the ascertainment ratio, right? Because asymptomatics or presymptomatics you cannot measure. So you have to have some idea of how much, how many are they, Because you only see cases, right?
Yeah.
The only data you have is cases.
No, but we estimated. Okay, the question, so we only see cases. So how do you really estimate asymptomatic and pre-symptomatic cases? Yeah, because we only see cases. Cases are confirmed cases. Yeah, they're not pre-symptomatic, asymptomatic. So, so what we did again, we estimated just the betas based on the data at that particular point in time. So we think that the whole, so all the new cases are generated by the four sources, pre-symptomatic, asymptomatic, symptomatic, and hospitalized. So all of those things are buried in the data. Therefore, if we use that data to estimate beta P and beta A and all that, we think that captures in the estimate, in the parameter estimation.
You only look at the cases for the fitting.
Yeah.
All these intervals, you are on the cases.
No, we look at the mortality data.
Oh, mortality and cases.
Yeah, not cases. Yeah, we look at the mortality data. Yeah, this is based on fitting the models mortality data. Yeah, that's good. That's very nice. Okay, but I should do the confidence interval later on. Yeah, I should do it. Okay, so now we made prediction. What's the impact of early lifting of lockdown with this? Okay, so conservative lockdown. Okay, so this is the period when we are in lockdown. Arizona, this is the shaded region, is for Florida, this is for New York. Remember, New York went in early and they stayed in, and the blue is baseline and red is the data, so baseline parameters. And we predicted what would happen, actually, what we think would happen in Arizona if everything remained the same, because we lifted lockdown very early. And we said if nothing else changes, and this is the sort of data that we predicted. This was published sometimes in August of 2020, this paper. And that was the estimate we had for, and we got a lot of hate, actually. People were writing, saying, no, your doomsday scenario is saying that terrible thing. But that's almost precisely what happened in the fall of 2020. Yeah, so we didn't really have a first wave in Arizona, so we had a second wave, which was massive. Yeah, because we lifted lockdown so early. The same thing in Florida, but look at New York. Because they stayed longer, they benefited from that. So the third wave was much milder compared to pretty much everywhere else in the country. This is for the entire country. So in any case, this is predicting that things is going to get worse if we continued on the same trajectory. So then we looked at, okay, suppose we, so here, actually mild reopening. So if we were not conservative in reopening, if we are more liberal, actually no, if we're more conservative in reopening, so which is mild, we do not say, okay, after the day of lifting of lockdown, you can go to restaurant, you can do whatever you want, you don't have to mask up. So that's a conservative reopening. But if it's milder and so on, so it's magenta color and the green color. So if it's mild reopening and moderate reopening, we have seen very different trajectories. So the fact that we lifted things immediately and didn't really put a lot of restrictions, that was what was responsible for this terrible thing. And we received quite a bit of hate at the beginning, but later on, people have to write back and eat up their words, which was good. I mean, yeah, I think it depended on mild reopening, meaning there's still a lot of restrictions, but you can probably go out, but maybe not go into a restaurant indoors. You can eat in the restaurant, but outdoors and away from people. So we have some criteria in the paper for what mild and moderate reopening is.
But then you would have to do that indefinitely.
No. Yeah, we said we have to do it until for a certain period of time until we really suppress the community transmission and buy ourselves time until we get a vaccine. Yes, that's what we say. Not indefinitely, but suppress community transmission, because that's the reason why we want to suppress community transmission. Also, it minimizes the likelihood of development of or emergence of new variants.
So your figures contradict a little a talk by Tom from a little while ago. So there are people who studied what is optimal policies for lockdown and things like that. And one of the things we learn from those that if you do early lockdown, sort of if you do lockdown really at the beginning before you have reached the peak, all you do is you delay herd immunity, and your curves, you never draw these curves to the end. So it could be that you would actually have a second peak. If you lock down, you will sort of not have herd immunity, but you still are in a region that are not as big, and it will stay big because you have lockdown. And then when you reopen, you just get the same curve delayed.
Well, it depends. You can delay, yeah. So here.
So I'm astonished I don't see that in your picture. Sort of, it should somewhere, at least for a little while, it should show up. If I lock down just in the beginning for a short time, you should just, if you do perfect lockdown, you should suppress.
Suppress the disease. But it may come back up again if you do not continue to.
Right, so you have to lock down forever.
Well, at least until the end of when we know we're going to have when we have a vaccine, then you don't need to lock down.
Oh, so are you assuming we lock down until we have the vaccine?
Until end, we run the simulation until end of the year, end of 2020. So we didn't, but I'll show you, okay, next slides will be much clearer. I'll do another one that's even more impressive, I think. So early implementation, okay, so this one is to say, okay, suppose we started lockdown like a week earlier or 2 weeks earlier. So magenta is if we started locking down in Arizona a week earlier than we did. And green dash line is if we started 2 weeks earlier and then we stay in lockdown until this duration, until what, June of 2020. So that's, so basically just what, yeah. Anyway, so this is what we predicted. So you see, instead of this is what actually happened, this problem. The data is red, and the blue is the baseline, using baseline values of our parameters, which fits the data reasonably well. But this is what would have happened if we started locking down a week earlier than we did. This is 2 weeks earlier than we did. So this would have suppressed the epidemic, especially in Florida and New York. And there will still be a appreciable epidemic in Arizona and in the entire US if we did this. So it's early implementation. So hit hard and hit early would have saved a lot of lives. And this is what this slide is showing. If we started just a week earlier, the reason is because, you know, at this.
But wait, I really want to correct you. If you start a week earlier and don't stop, if you start a week earlier and actually stop a week earlier, I think calculations show you get more deaths, not less deaths.
More deaths if you.
So if you want to reduce the number of deaths to a minimum, you should actually start at the peak. But that's only if you give yourself only, let's say, 2 months. If you give yourself until you have the vaccine, I agree with you.
Yeah. So what here we didn't start at peak. We just said, well, suppose we started our simulations like locking down with all these parameters. Locking down means, okay, how do you implement lockdown? It minimizes your contacts. Okay, so the betas are reduced by a certain scale that we specified at the beginning. If that was implemented a week earlier or 2 weeks earlier, this is the trajectory of the disease we have. We will still have a peak here, but it's much milder compared to what happened over there. So the mortality would have been suppressed greatly if we do it that way. Anyway, okay, so what else? So what about masking? So now that was lockdown. If we started locking down early and stayed a little longer, we could have saved a lot of lives. This is masking. So here we had data for the 3 waves and we fitted the data, cumulative mortality. Red is data, blue is the model, and this is the daily mortality also. So we fitted the model here and then use the fitted parameters to predict or to see whether or not our model matches the daily observed case. This is not easy to do actually because it's 3 different waves, but somehow it looks reasonable, and there's some of the papers here. The question we wanted to address, okay, well, suppose masking is the only strategy we have. Nothing else. We're not locking down, conservative or not, I like that one. Suppose we only masking. Can we do much better if we had done something slightly different? If the strategy is just based on masking alone. Okay, so let me show you. So here, so we run simulations. What is the impact of early implementation of masking strategy? Okay, so and this is, okay, so here we started masking 4 days after the WHO declared COVID to be, and this is only for the United States, to be a global pandemic. So on March 15th, March 11th was the declaration by WHO. So if we started masking, and then we'd have different types of masks. Okay, there are 4 different types of masks. Either a closed mask, which has efficacy of about 30%, essentially improved one, which is about 50% efficacious, and the surgical mask, nobody's wearing surgical mask here. No, okay, it's about 70%, and then the N95 mask that Tran is wearing, so it's green. Okay, so if we started just 4 days after, this is what we predicted. This is the baseline, the blue, and this is what would have happened in terms of cumulative mortality if majority of the people, 80% of the population, wear masks every time they're in public, and if the masks, if we prioritize only the cloth mask, which is basically ineffective one. So you see that there's some savings in mortality compared to the baseline, but it's not very significant compared to if everyone of the 80% that go out wear N95 masks. if we all, okay, so 4 days after WHO has declared a pandemic, if 80% of us go out, every time we go out, we wear N95 masks, and correctly, of course, we know the tight seal and all that. This is what we predict the pandemic would have been. Huge savings in terms of mortality. And this one is, if we started, this one I think is, if we started on 18th of February, which is like 2 months after the index case in the United States. Yes, sir.
I'm curious, like how the in terms of the models, how the masking effect and the lockdown are different in the models.
How is the masking effect and the lockdown?
I mean, where the parameters come into the models?
Or okay, so here we have 2 different types of models. That's one model which stratifies the population as a group model, those who wear masks consistently when they go out and those who do not. So the first paper I showed, the to mask or not to mask paper, this one has that. It's a group structured model, okay, with that. But the other one is just masking is to reduce your probability of transmission. It has 2 main efficacies, right? Masking is the inward efficacy. If I'm susceptible wearing a mask, it protects me from getting infected if I come within 6 feet of somebody who's infected. So it has the inward efficacy, but it also has the outward efficacy. If I'm infected and wearing a mask, my probability of transmitting to you, if you are susceptible and you're within 6 feet, is reduced. So that's how we met. So it's in reduction in my contagion capacity or ability to get the disease. So we modify the betas by just putting the efficacy.
A follow-up question. So your social distancing would just be a perfect mask?
Essentially, yeah. Yeah, essentially. But then the question of social distance, that's a study which shows it's not 6 feet, and the optimal distance is there's this
lockdown is a perfect mask.
Well, it depends if it's perfect lockdown also. Yeah, lockdown is a perfect if you stay home, yeah. Yeah, if you don't go out, because you may, during lockdown, we still have to go to the grocery stores, do certain things, right?
Yeah, but your model didn't have that, right? You assumed perfect lockdown, no?
This one here?
When you showed us the data, did you assume that you have 1% leakage in lockdown?
Oh, yeah. In the simulations, yeah, the lockdown was not perfect. Oh, yeah.
I see. So what percentage did you assume?
I cannot remember the percentage, but yeah, the lockdown was not perfect because people in lockdown, you still have to go do groceries. You have to still, there's emergency service people who have to still be out in the street doing certain things. So that we accounted for that. I do not remember the exact figure for that. Yeah. But there's no such thing as, except in Wuhan. Wuhan actually had almost perfect lockdown. Nobody was really going out. So they had a way to deliver food to people. Like, anyway.
Wait, didn't people claim that like risk transferred across like beds and stuff, like even in the lockdown, like within
do people account for risk transfer? What?
Not accounting, yeah, like even an event, like an event of like tourist.
Oh, vent. She's asking whether the vents in a room wouldn't transfer.
Oh. Yeah, that's a very good question. Also, yeah, we didn't account for that in the modeling, but I know.
I agree with you that I think even the lockdown didn't work perfectly because.
Yeah, of course. Yeah, no, I like that. Yeah, thanks. Okay, so if we started like 2 months, even 2 months earlier, this is what we're predicting. The point is, if we be all using N95, the disease would have basically failed to take off. Even if we started like 2 months earlier, 2 months after the index case of the United States. You know, if everybody, so what we're saying now, if we stockpile N95 masks and make them available to everybody during the next pandemic, yeah, and if everybody wears that, we do not even have to shut down the economy. There's no need for lockdown. This has no lockdown. This model just, all we have is just this, using this mask as the only.
So what's your assumption of R naught? So for example, now R naught is supposedly to be 20, so an N95 just gets R naught to 1, and if it's not worn perfectly, it will not quite help.
No, not done.
So,
no,
right?
No, we're saying 80% of the population wear N95 masks every time they go out.
So if you have 80%, that would just it would just reduce R naught to 20%. So if R naught is 10, it's still 2.
Well, here, so we're looking at cumulative mortality. So it's not cases. But mortality.
But what was your R naught in this?
I don't remember what the R naught was in this case, but I can check that quickly. But I don't know whatever it is definitely suppressed because not a lot of people are dying. There may be a lot of cases like we're seeing now with Omicron, a lot of cases, but mortality nowadays is definitely not what we used to get. I mean, we used to have like 3,000 people dying in the US every day. So nowadays it's what, maybe 100 maximum. Does anybody know what the mortality data is for nowadays? Less than that.
Last time I looked, it was more than 100.
I think, by the way, we are slowly running out of time. Like, very fast.
I have to. Okay, I have a lot of more stuff to do. Okay, quickly.
So I give you. Well, I have a meeting I have to run to. So I will give this microphone to Amin at quarter past.
Okay, good. He's my friend. He's going to give me a lot of time.
Yeah. Bit over 300 a day right now.
300. Oh, okay. So it's not. Okay, I take back what I just said because I thought it's less than 100 a day. Yeah. But it's still compared to 3,000, that's still.
You suggest that a good, I mean, N95 mask would be perfect, but are you sure that for the next pandemic, this will be the good tool?
No, if it is a respiratory pathogen like COVID, yeah. If it's a pandemic of respiratory infection, yeah, that spreads through respiratory droplets, yes. But we have no idea what the next one could be. Ebola, which is contact-based pandemic. I mean, it could be Ebola, could be so. But if it's respiratory, if it's COVID-like pandemic, then yes, this will be fantastic tool to do it. We do not have to shut down the economy at all if everybody wears N95 mask correctly and consistently. Yes, Jorge.
Question. You can repeat the question?
Yes, I can.
You were looking at controlling mortality, right?
Yes.
But what if you control infections?
Cases are.
Is that the same?
We didn't check that. That's a great point. We're looking at these figures are comparing mortality or checking savings in terms of mortality, what percentage of people, the 1 million people that have died, how many of them will be saved?
In terms of hospital capacity, for example.
The what? Hospital. Oh, yeah. That's a good point.
That kind of thing.
Well, yeah. So this is correlated with hospital capacity because most of the people are dying in hospitals. So
yeah, but it's different, right? Because you need the capacity of the hospital.
Yeah, how many beds can we have? Yeah, I know. New York at some point didn't have enough beds. Yeah, but we didn't do it that way, but that's a very good point. Can we produce this results in terms of hospital capacity? Yeah, that's a very good point.
Okay. May I suggest that we hold questions? So Abba can end at 12:15.
Okay.
And we can always
continue
the discussion later on.
Okay. All right. Now the game changer moment. This grandma, Margaret Keenan, the first person to receive a COVID vaccine in the United Kingdom. Yeah, changer moment in the world. mRNA vaccines approved for use by FDA and around the world. So I think she got the Pfizer vaccine, although quite a large number of people get the AstraZeneca, but she got the Pfizer one. This is the very first case in the UK. Anyway, that changed the whole landscape. It was great. The whole point of mRNA vaccines, the strategy or the solution process has been going on for decades, in like 3 to 4 decades. Actually, people have been working on this. They built a platform and luckily it worked. Anyway, so these are the vaccines, the efficacies, the dose stretcher, the structure, boosters, and all of that. Anyway, so I think we all are familiar with this, so I probably wouldn't go into too much detail because of time. But these are the 4 vaccines that are being used in the US. So, and AstraZeneca is used around the world, but I think not here in the US. Right? Yes, sir.
What do you mean by efficacy? Because
okay. So there are 2 types of efficacies. Okay, so here, so the efficacy of the vaccine is measured in 2 ways. One, when the pharmaceutical people talk about efficacy, what they're talking about is efficacy against severe disease, hospitalization, or death. That's what they mean. But here, in our context, in modeling, is efficacy to protect a vaccinated person from acquiring infection in the first place. So there are 2 main types of the protective efficacy. There's also the therapeutic efficacy. So therapy, so when they say it's 80, so almost all of these vaccines are 85% efficacious with respect to therapy. So if you got it, you have 85% chance of not developing severe disease, 85% chance of not getting hospitalized, and 85% chance of not dying if you got the vaccine. Any of the, I don't know about Novavax, but any of the 3 that have been used in the US. It has those fantastic, in fact, COVID, after the vaccination was implemented, became now the disease of the unvaccinated people. So if you're vaccinated, the chances are you won't get infected. Even if you do get the breakthrough infection, you're not going to develop severe disease, and you're not likely going to be hospitalized, and you're certainly not likely to die of COVID. Well, that's a great question. Yeah, so they're highly efficacious. I don't remember the last time we had a vaccine that's this 95%. Maybe measles vaccine is maybe human papillomavirus vaccine. But I don't know of any other vaccine that has this. Does anybody know any that has this level of efficacy? Yeah.
Sorry, I think we should let Bob finish.
Oh, sorry. Okay. Yeah. Okay. All right. So variants. That's another great thing that happened with respect to COVID. Actually, this genomic surveillance around the world, particularly in Israel, in South Africa, in UK. I think they've done fantastic job in Germany also. As genomic surveillance, Omicron was detected by the genomic surveillance team in South Africa, actually, and they may have saved the world of disaster actually by telling us about Omicron ahead of time. That was really great. So anyway, and this is the data for case data, daily case. So in the US, we had about 100 million confirmed cases, which maybe multiply that by 4 at least. And also, unfortunately, over 1 million people have died. So these are the daily cases, this daily mortality. And this is when Delta hits. This is the region when Delta was the only game in town, and then it was displaced by Omicron sometimes in the fall of last year. Anyway, so we wanted to model this. And this is herd immunity, but I think I'll skip this. I think everybody knows what it means, but but Tom is here, so I should mention. Anyway, so we did a model of vaccination, the same pretty much as the previous model, but now we added demographics because we're vaccinating younger people or children, children 6 months and older, I think. Anyway, the same force of infection, but this is the vaccination rate. So vaccinated, unvaccinated SU, SV are vaccinated susceptibles. So here we have differential susceptibility, and epsilon B, the efficacy of the vaccine to protect you from getting infected. So it's a number between 0 and 1. So if it's 1, then there's no breakthrough infection. You don't get infected if you're vaccinated. Anyway, so the rest of it is the same. But now, if you recover, so that's demographic parameters are included. Lambda and mu are included in this model. Okay, and then we fitted the model. This is during the Omicron, when Omicron started, so we fitted the model. And in fact, we have data up to here, but we withheld 1 month of the data to use, okay? So we fitted up to here, but then we withheld 1 month of the data that we already have for cross-validation purposes. So basically, we're training the model here to see whether or not it can reproduce or it can capture this 1 month of data that we already have. So it's called cross-validation, and it works nicely, and therefore we can make predictions. And this is why we predicted it was Omicron. It was basically going to die out by sometimes March of this year, and pretty much was going down. So, and this is the cumulative cases in this case. Here we use case data. So, okay, so we calculated R0 for this model. It's not R0, it's RC because we vaccinated people. So it's given by this. So it just reduces R0 by this, a factor of 1 minus epsilon V. Epsilon V is efficacy, and FV is the proportion vaccinated at steady state. Okay, so if epsilon V FV is 1, of course, then the disease essentially dies out, right? If everybody is vaccinated and we have a vaccine that's 100% efficacious, then the disease has no chance. It's gone. And we calculated the herd immunity threshold. This is for homogeneously mixed population. So you just set this equal to 1, that's a verification point, and then you solve for the proportion FV that's vaccinated at steady state. And that's a classical definition of herd immunity threshold for homogeneously mixed population. And then you can write your disease-free equilibrium, local asymptotic stability in terms of this herd immunity threshold, which is given by the RC less than 1, you have a chance to control the disease. Greater than 1, the disease will persist. Fantastic paper by Tom Britton on this. If you do not have a homogeneous, if you have heterogeneous mixing, the herd immunity threshold is a lot more complicated than this. And in fact, the requirement for herd immunity is lower compared to when you have homogeneously mixed population. We followed up on that and actually wrote a paper looking at more theoretical aspect of this, but same idea, essentially. Okay, so I have to stop now? Yeah. Okay, well, let me just go. You have to give me this 1 minute. Just, okay, what will we do differently? Conclusion. I'm the organizer, yeah, okay. Yeah. So these are the conclusions, but what would we have done different? How to mitigate the next one? Address the problem from the source. Mitigate anthropogenic climate change. Okay, habitat destruction. All of those things that making us vulnerable to getting in contact with wild animals and so on. Doing all these terrible things that we as humans do to the natural environment. Address the problem from the roots. So unless we address the problem of climate change, of land use changes, wildlife farming, and all of these things, we're going to continuously be introduced to new deadly diseases. So realm of genomic surveillance, we have to be doing that, a lot of that. We discussed that during a break. I think Greg, we're talking about, the need for surveillance, genomic surveillance, testing people randomly to see whether there's something going on in the community before the CDC is aware that it's already an outbreak. So early detection of respiratory pathogens with pandemic potential. Stockpile and early deployment of highly effective masks. Make them available and make them available to everybody at the beginning. So, and what else? Early implementation of effective control measures. Lockdown should be implemented early and for optimal duration. So Wuhan did it for 76 days. Fantastic. 76 days, it worked. But it was real lockdown. Conservative, oh, she's not here. Conservative lockdown in Wuhan. Hamza is not here. Okay, early implementation of masking using N95 or equivalent. So there are masks, but there are also masks. If we prioritize N95, make them available, this would have, we would not even need to lock down. We would not need to shut down the economy at all if everybody or majority of us in public are using N95. This is what we have showed. Public health messaging, of course, to counter misinformation, disinformation. So we need that. We really have to do that. And I'm glad we're having this workshop on misinformation, information diffusion. Free at home rapid tests, make them highly effective DNA type tests that people can do at home to test themselves, because that's the only way we can detect asymptomatic, pre-symptomatic people. And they are the main drivers of this epidemic. So unless we have large scale testing that people can use at home, for example, or a random, large scale random testing, we may not be able to detect asymptomatic and pre-symptomatic, and they are the main drivers of the epidemic. Improve the efficacy of the mRNA vaccine. Well, they're already 95% efficacious, so we may not need to do that. Economic incentives. So we talked about, I think yesterday, about the meat factory workers who, even though they know they are risking their lives to have to go to work, but they have to do that because that's the only source of livelihood. They have to take care of their families. So we have to provide incentives for people like that so that they can stay at home without. So One Health approach to public health. So not public health just focusing on humans, no, humans and animals and the environment. One Health approach. And despite doing all this, hope that the next one is not going to be as contagious as Omicron and as deadly as Delta. So we still have to hope, despite all of those things. So yeah, we've seen this movie before. See, we've seen this. We've talked about COVID. Now look at all these deadly diseases we've seen in history, human history, killing large number of people and other outbreaks. They are all zoonosis. They're all jumping from animal population to humans. We have seen this movie before, this terrible movie before. And most of these are originated from, so we had since the 1980s, I mean, outbreaks of deadly diseases, this kind of diseases, increasing since the 1980s. Each decade is like 3 times the previous one, the number of outbreaks. Some we know, some we do not know. So the number of new outbreaks are increasing at an alarming rate. And they are mostly about 70–75% are originating from animal populations. It's things we do to the animal populations that makes us vulnerable. Okay, yeah, so the consequences of continued interference with natural ecosystems, destruction of habitat, deforestation, agriculture, and all of these things. Okay, anyway, I see Amin is raising off, so I have to stop here, and thank you for your time, but this is the whole picture, yeah. Okay, thank you, Bart.
Thank you for a great talk, and we will continue the conversation throughout the week.
Okay. Yes, I like that. Sorry, I've taken too long. Yeah.